these problems, they develop for when you look at it for very understandable reasons a lot of the time. So if we think about psychosis from a psychological understanding, then there's this idea and view that psychosis is often a response to things that happen in our lives. So particularly things that are really traumatic or stressful. There's really good research to support this as well. So some of the research, these associations between trauma and psychosis, and like childhood trauma and psychosis in later life. And that level of association that they found is quite similar to smoking and lung cancer. It's quite a strong link. And also we know there's a sort of dose-response relationship between these things as well. So the more trauma that someone experiences, the more likely they are to go on to develop problems with psychosis.
Hi, I'm Naomi Murphy, and this is the Locked Up Living podcast, where we talk with a wide range of people about harsh aspects of institutional life.
We also explore some of the ways to overcome them and to grow and develop. I'm David Jones. So join us every Wednesday morning, 6 o'clock UK time, for a fresh podcast.
So today you're going to hear from Dan Lawrence. Dan is a forensic psychologist who's based in a secure mental health service in South Wales, where he provides input into medium and low secure services for men. He's also a PhD student, associate tutor and academic supervisor at Cardiff Metropolitan University. Really pleased you could join us today, Dan. Welcome.
Oh, thank you very much. It's a real pleasure to be invited, actually. I should mention that I'm a big fan of the show, and I've been listening since you started as, I suppose, a bit of a side hustle maybe in lockdown. So yes, it's a real pleasure to be invited to speak with you both today.
Thank you.
Hi, Dan. That's a very nice thing for you to say. Thanks very much indeed for that. I'm interested to hear about your service, actually, because I've visited several approved premises in South Wales, Swansea and Cardiff, and they both had a connection with the local forensic service, which is extremely unusual across the sort of breadth of England and Wales. Anyway, that's a by the way.
Yeah.
Dan, can you tell us something about your career pathway? Did you always want to be a forensic psychologist?
Yeah, of course, no problem. It's a bit of a convoluted journey, actually, so I'll try my best to keep it succinct. So no, the short answer is no. I didn't always want to be a forensic psychologist. So I come from like a working class background, and I grew up in quite poverty stricken area. So those sorts of careers were commonplace, I guess. My sort of awareness of those sorts of careers was quite limited during my childhood and stuff. So actually, it wasn't until I got to university actually that I really started to become interested in being a psychologist. So I was always really, really interested in sport when I was growing up. And if you're from the part of the world where I'm from, that's more often than not, that's rugby. There's always real ambitions about being a rugby player. And when it came to sort of picking and deciding and applying to go to university and stuff, I was really more focused on the sports side of things. So my thinking was around this university has got a really good sport and in particular rugby setup. So psychology sounds quite interesting. So I'll just do that degree. I can really focus on the sport. I suppose I always had a bit of an interest in sort of like true crime sort of books and shows and films and stuff. But then what happened was when I got to university, I didn't end up playing any rugby at uni actually, and I was then all of a sudden just kind of was stuck with this psychology undergraduate degree. So I had to sort of pick it up and run with it, I guess. And it was quite early on I realised that it was the forensic and the clinical sort of aspects of it that appealed to me the most. So I started to just look at what you need to do to become a forensic psychologist, and then try to do what I need to do, getting experience and knuckling down a bit with my studies and things like that.
So why didn't you do any rugby?
So I picked up some injuries is what happened in the end. Yeah, and then it just became, it got to the point where it just wasn't worth it. It was sort of repeated injuries, so it wasn't worth trying to persevere with in the end. I was spending more time sort of sat on the sidelines than I was actually playing, so it just fizzled out in the end.
Yeah, it's a pretty tough sport, isn't it?
Yeah.
So did your forensic training prepare you adequately, do you think, for working in the mental health settings?
Yeah, I think it did actually. So all my experience prior to starting my psychology training was in predominantly in mental health settings, and then mental health settings was where I did my training. So the sort of on the job learning and training that you do when you train to be a forensic psychologist, that was all based in secure mental health settings. And I think, more and more what I've learned as I've developed in my career and gone along is that actually there's such an overlap between people who use criminal justice services and mental health services and secure mental health services. The stories are so often very similar. They come from the problems people present with often come from a place of adversity and trauma. So I suppose what we end up working with in all settings really is very human problems, not like prisoner problems versus mental health patient problems, if you like. And of course, there's high level of mental health distress across all aspects of the criminal justice system as well. So there really is quite an overlap. So I think with that in mind, the training really did prepare me quite well. And I think those sort of core skills that you develop as a psychologist are the areas that you really have to sort of just develop and evidence your ability to be able to do them. It just set you in good stead to work with people from all walks of life, I think. And you think of things like good communication skills and that sort of thing. I suppose maybe the clinical training compared to forensic psychology training perhaps might have given me a bit more of a comprehensive grounding in like therapy models and providing therapy and things like that. But overall, I think it prepared me really quite well.
How did you decide to opt for one rather than the other?
I think it was just around at the time access to the particular course. So I'd finished my undergraduate degree, and then my initial idea was about trying to get onto the clinical psychology training, and then you start to learn that that's really quite a competitive place to try and get on. So it was really about trying to develop my experience and I guess my qualifications to make me more appealing perhaps to a clinical course. So I ended up doing a master's in forensic psychology, and then the university where I did that, so Cardiff Metropolitan University, what they provided then was quite a nice, straightforward way to transition from the masters to the postgraduate diploma in forensic psychology that they offer. So it's all the same. It was kind of like the same staff team who would be doing the masters. So it was just an easy, quite an accessible course to get on at that time.
Thank you. I mean, I find that very interesting because forensic psychology is notorious for its kind of limited clinical practice components, and yet the pathway you followed seems to have been extremely clinical. So you specialised in working with people who experience psychosis. What are some of the challenges people with psychosis face? Yeah,
so I suppose it might be helpful to think about what it is that we mean by the term psychosis, and like pretty much any definition of some sort of term or concept that we talk about in our work. If you type the term psychosis into Google, or you come back with is like 1,000 slightly different definitions of what the problem is, but where they all seem to agree and what they're consistent about is that it's a type of problem, it's a type of mental health problem where the person experiences some level of departure from reality, I suppose. It's quite often used interchangeably with terms like mental illness, schizophrenia, and then perhaps more negative or pejorative terms like madness and lunacy and things like that. So when people develop this type of problem, what happens is that they tend to experience some really quite unusual things. So some of the things they might develop problems with is like they might be sensory in nature. So they might have some quite unusual sensory experiences. So perhaps like a quite common one we see in our services is some people might hear voices when there's no one there or no one talking. They might see, less common, but they might see things, smell or feel sensations that are unusual as well. Then at other times, their problems may be to do with like holding certain beliefs that seem to be a little bit unusual or a little bit unlikely, but these beliefs can become really quite fixed and I suppose held on too strongly despite evidence that seems to be of the contrary or seems to undermine the beliefs. And if we were to put like medical language on these terms, we might refer to them as delusional beliefs. So quite often in secure services, those beliefs are kind of held in with like a paranoid theme or paranoid flavour to them. So they're usually about people wanting to harm or persecute the person in one way or another. People might believe that they're really important, talented, or special, or powerful in some way. Then other people might have some sort of disruptions to the way that they think and that they feel. So they might experience some problems where their thoughts become like jumbled, or they might have difficulty communicating them. Some people might jump around between topics when they're talking to people, so making it really quite difficult to follow and understand what it is they're trying to talk to you about. Then others might have problems like with regulating their feelings and their behaviours, and have problems managing things like anxiety or anger, and then their kind of behavioural responses to these feelings. Then others can they can be quite withdrawn. They might isolate themselves. They might lose interest in things that they did previously. They might feel sort of unmotivated to do things. So I guess it's a very, very broad term, which it encompasses a lot of different types of problems, really. And it's probably worth noting that whilst we do have these overarching terms like psychosis and things like that, these experiences do tend to differ quite a lot between different people, even though we might talk about two people as having psychosis, if you like. It's likely that the sort of specific things that the people experience differ. So two people might hear voices, but the content and the level of distress they experience might be completely different, and kind of the same with the beliefs that people hold as well.
Thanks, Dan. That's a very full and clear answer you've given there. Do you think there are ways in which psychosis might be adaptive?
Yeah, definitely. I think these problems they develop for when you look at it for very understandable reasons a lot of the time. So if we think about psychosis from a psychological understanding, then there's this idea and view that psychosis is often a response to things that happen in our lives. So particularly things that are really traumatic or stressful. There's really good research to support this as well. So in particular by the great Richard Bentall, as we refer to him here. So some of the research he's done with colleagues has found associations between trauma and psychosis, and like childhood trauma and psychosis in later life. And that level of association that they found is quite similar to smoking and lung cancer. It's quite a strong link. And also we know there's a sort of dose-response relationship between these things as well. So the more trauma that someone experiences, the more likely they are to go on to develop problems with psychosis. And then if we think about trauma-informed or perhaps trans-diagnostic models of understanding people's difficulties, so something perhaps like the power threat meaning framework. we can start to think of like experiences that often get called symptoms as being strategies that were developed in order to keep somebody safe or respond to a threat that they were experiencing in their environment, perhaps. So to paint a bit of a picture, if we think of somebody who's grown up in perhaps an abusive home environment where it was common for them to be hurt, then it would have been really helpful for them to be able to be vigilant to the possibility that somebody was going to hurt them, and to sort of pick up on subtle signs that abuse might be about to happen, perhaps. And of course, it would have been helpful for their safety to perhaps be suspicious or mistrusting of the person who was being abusive towards them. So those things are really, really helpful in that context. But of course, when they become exacerbated, or perhaps if they continue when the person is no longer in a threatening environment, then essentially what we're describing is paranoia. You know? So, and there's a really interesting recent research paper as well by the cognitive approaches to psychosis team at Oxford University, and where they've started to look a little bit more at what was sort of classically being called grandiose delusions, because I think the majority of the research that has looked at these sort of unusual beliefs it has tended to focus more on paranoid beliefs rather than grandiose beliefs. So they started to have a little look into this experience as well, and actually what they're suggesting is that we rephrase it and refer to it as beliefs or delusions of exceptionality rather than grandiose delusions. And what they theorized is that these types of beliefs kind of develop for people to provide a sense of like purpose or belonging or self-identity, perhaps where those things have been lacking. I think the reference is Isham et al. So it's a really interesting paper. And then if we start to think as well then about other experiences that fall under that kind of broad overarching term, psychosis, or something like voices, there's a really wonderful TED talk by Eleanor Longden. I think it's quite old now. It must be about 10 years old, I think, where she talks about her own experiences of hearing voices. And what she came to realize was that the voices were the expressions of trauma and abuse and emotional problems that she never had the chance to process and resolve. And of course, what we're talking about as well is that very human processes, so that many people experience from time to time. But I suppose when we talk about like clinical psychosis, then we're thinking about the extreme end of those processes and experiences. So, for example, many of us have felt a little bit suspicious or paranoid when we've walked into a room and all of a sudden everybody stops talking, or perhaps when we're walking alone late at night or something like that.
That's a really helpful explanation of how adaptive and normal in the context of someone's life those experiences may be. I was just wondering though, some of those things that you're describing, we see similarities within the prison system, for instance. Perhaps a lot of people that would meet diagnostic criteria for narcissistic personality disorder in the case of the grandiosity or exceptionality, which is a nicer way to put that, or paranoid personality disorder. Do you have a sense of what it is that causes that extra fragmentation for some people, where they become totally detached from reality and end up having these experiences? What makes a difference that where somebody becomes psychotic as opposed to perhaps wouldn't be described in that way? Does that make sense?
Yeah, and I think that's a really good question. It's probably quite difficult to answer with any certainty, I think. I don't know whether there's something about I don't even know if there's something about the severity of the experiences that might, or whether it just comes down to sort of personal, like individual factors for the person. And of course, it becomes all the more tricky, doesn't it, when these problems overlap and get intertwined as well. So quite often in forensic services, we might see somebody whose psychosis stabilizes, but then we've still got those kinds of like personality traits underneath as well. It's probably, if I was to theorize or hypothesize about it, I'd say it's probably something to do with the meaning that people make about their experiences, and how, I mean, perhaps there's kind of like the degree of threat and the need to respond to that threat, maybe. Yeah, but that's a really, really good question.
No, thank you. I appreciate you kind of like making an effort there to answer that for us. I think what you're really highlighting is just how complex it is when we're talking about people whose problems intrude and cause a lot of distress for them in quite extensive ways. So thank you.
Yeah. Do you, like, just out of interest, do you have any thoughts about that, Naomi?
No, I don't. I suppose my inclination was like yours, to think that maybe there's something about the severity of the experience being so great that maybe as a younger person, the only way to cope with that, like you say, to be to try and compartmentalize it in a way that perhaps somebody whose the personality is adapted to incorporate the belief is able to hold on to some sense of consciousness, and in terms of consciousness and deliberateness of the rules that they're living their lives by. But no, I don't, and that's why I was curious to hear what you had to say. Thank you.
And you gave a great description of the sort of varied nature of psychosis and its adaptive forms. Do you think those phenomena pose a challenge to service providers?
Yeah, I think they can, and I think sometimes where the challenge is, so sometimes those experiences can be really quite hard to make sense of. I guess they can be quite confusing, maybe, and a bit overwhelming for clinicians, because of course they seem quite unusual, and it's sometimes quite difficult to put your finger on or figure out what it is that the person's trying to communicate with you. Then of course it's difficult to know how to support that person or what treatment needs to be provided, I guess. So that can be difficult, and I think one of the problems as well is that still our kind of understanding, or the predominant model for viewing these problems in mental health services is a really sort of medical approach to it. So if we think of like symptoms then as being safety strategies or threat responses, but if we think of the safety strategies and threat responses people develop to help them keep safe, if we view those as being just symptoms of an illness, then we kind of run the risk of only really addressing problems at the surface level, and we might miss or perhaps ignore the underlying function and why the problems develop in the first place. So, essentially what we might be doing by trying to get rid of or cure somebody's symptoms, if you like, is that we're encouraging people to drop long-standing safety strategies without helping them to develop a sense of safety in other ways, perhaps, or to be able to manage threat in other ways. And then that's kind of, what people there's a saying that services sometimes are mopping up the floor before they turn off the taps, if you like. And then the other problem is that many people, they don't report positive experiences of mental health services. So we know that like iatrogenic harm is a real risk, and it can be a problem. And then some people refer to themselves as like survivors of psychiatry and describe how their time in services was hugely distressing and traumatizing for them. So the problem there, the challenge to services there, is that if we think about psychosis and other mental health issues as being a reaction to life events such as trauma and adversity, and if when people come into services, they're experiencing further trauma or becoming re-traumatized, we really do run the risk of compounding or exacerbating the very problems that we're trying to support people with, or trying to do something about. And that might be then why some researchers and some authors have observed that outcomes for psychiatry in terms of people's recovery have improved very little for a long time.
Thank you.
Thank you. It's a bit depressing to hear, actually, that even in specialist services for psychosis, that there's still that tendency for the medical model to prevail, given how much we know about how people's histories play a part in their current presentation. But that was really helpful to think about how people might be experienced as being a challenge. I wondered whether there are any special measures you would recommend to a clinician in order that could help engage somebody with psychosis in treatment, if you've got to overcome these barriers of trust.
Yeah. So I suppose, generally speaking, the way in which we engage with people who experience psychosis doesn't differ a great deal to anybody else, really. But as you've alluded to, Naomi, the barriers to developing the relationship with the person, which of course we know is of huge importance. If treatment and therapy is going to be any good, we need a good therapeutic relationship. So the barriers, I think, perhaps a little bit more evident, maybe, or a little bit more tricky to overcome with people with psychosis. So, for example, if somebody feels very suspicious about other people or mistrusting, of course, it can be more difficult to develop a trusting, safe relationship with your team or your therapist for obvious reasons, really. If somebody's struggling to communicate or their thinking is really jumbled up, perhaps, for example, then building a relationship and engaging in the process of treatment and understanding everything can obviously be really quite difficult. So the key really is to think about how we might overcome these barriers, I suppose. So, for example, if someone's really suspicious or struggles to trust other people, then perhaps we might start with a really gradual approach to building a relationship with them, starting with just making ourselves seem like more present and familiar to them. And then like things like validation and expression of concern and empathy about people's experiences, I think really helps. And a lot of the time, like trying to challenge the perhaps unusual beliefs head on, or trying to convince a person of what they're experiencing isn't real, it's just part of a mental illness or mental health problem, really does get you nowhere. And what it can lead to is like really getting bogged down in content and debate about people's experiences, when of course what we really want to do is help people with their distress. We want to work with the distress. And quite a lot of the time when people, especially when people have been in services for a long time, they've more often than not been repeatedly told that they've got a mental illness and you're just mad, what you're experiencing really isn't real. So just helping to or provide, in a sense, for the person to feel believed, really can be really helpful for them. And then perhaps like I was talking about just now, when it can be quite tricky for services and practitioners to make sense of somebody's difficulties, because sometimes the experiences that people voice and communicate to us, they don't make much sense. If people are sort of started to depart from reality a little bit. So I think sometimes we do have to think outside the box to try and figure out what it is that a person's trying to communicate, or what emotional experience their distress represents. And just trying to like connect the dots for them, and perhaps for the teams that you work in as well. I think that can be helpful. And I do feel like I've given my medical colleagues a little bit of a bashing this afternoon, but I do think there's a place for medication as well, particularly with people who are experiencing the highest, most severe levels of distress, even if that's just to kind of reduce their distress so they can get to the point where they can engage in other interventions or work towards their goals or whatever it might be.
Well, in terms of redressing the balance, in terms of input from psychiatry, have you read Brain Energy by Chris Palmer?
I've not. No.
It's quite a new book, but it's written by a psychiatrist, but he argues that all mental illness is a metabolic disorder of the brain, and that's the common factor. I was a bit reticent to read the book, thinking, it's going to be going down this biological model. But he was on the Andrew Huberman podcast talking about this Brain Energy. theory, and it's really fascinating. So using a ketogenic diet, they had patients who had symptoms of psychosis who became symptom free by eating a ketogenic diet. They couldn't then go on and eat cake or bread afterwards because the symptoms would recur, but actually found a really powerful effect of eating a ketogenic diet. I mean, I think it's a book that all mental health professionals should read, actually. Is not dismissing the role that trauma plays in the onset of symptoms, but actually I think when people have really quite distressed by the kinds of symptoms they have, I think he's got some really thought-provoking ideas about the origin of mental illness.
Yeah, that sounds really interesting, actually. I'd be, if you can pass the reference over to me, Naomi, I'd be really grateful.
I will do. And, I think we could have actually held a whole conversation probably about psychosis with you today, Dan. But I also, recently read a paper that you were part of producing that was referring to restrictive practices. And so I really want to move on to talk about that for the second part of the interview. And you're part of a team that's been exploring the use of restrictive practices within psychiatric settings. Can you describe what you mean by restrictive practices in the first instance? Yeah,
of course. And I should probably mention that this is the so restrictive practices and reducing restrictive practices is the kind of topic of my PhD research. So as anybody who's ever met a PhD student will know, there's nothing more that PhD students like to talk about than their PhD research. So I will try to keep it, like I said, succinct and try to stay on topic. So yeah, restrictive practices. So in mental health settings and other care settings actually as well, I suppose they're things or interventions that staff carry out that restrict the movement or the liberty of the service user. And the primary aim of them is to manage the risk of harm that a service user poses to themselves or others. And the idea behind them, or the idea for them, is that they're only ever used as a last resort when again, there's immediate risk of harm. So the terms restrictive practices and like restrictive interventions get used interchangeably in practice and in the literature and stuff. But Ada Huey, I think, was based in Nottingham, or at least she was, provides a really quite helpful definition and distinction between these terms. So restrictive practices is an umbrella term that's used to describe like the broader restrictive aspects of a ward environment, so like locked doors, restrictive rules, policies and dynamics. And then within this broader concept sit restrictive interventions. So I suppose restrictive interventions then I sort of view as being the most severe or extreme restrictive things that staff do to manage the risk. And I suppose they're where most of the focus has been in the research literature and in terms of clinical efforts to try and reduce the use of restrictive practices. So the main restrictive interventions that we have and that we see are like physical restraint. So that's where like staff will use their body to restrict the movement of the service users, put them in holds, hold them down, that sort of thing. We have seclusion, which is basically locking somebody in a secure room, so they don't have the option to get out. Chemical restraint, so that's where you might use like medications that are not prescribed for like a health problem. So it's about perhaps slowing or sedating somebody to make their behavior more manageable. And then less used in this country, but used more commonly in other places is mechanical restraint. So that's where you're using some sort of like device or object to restrict somebody and stop them from moving or doing something. And I suppose like under the mechanical restraint is where our perhaps quintessential restrictive practice sits when we think of things like strict jackets, that sort of thing. And I should just add that the terminology, so the term restrictive is a very UK based terminology. So in other countries, these things are often referred to as coercion. So coercive practices and coercive interventions is what they most commonly get called elsewhere.
Thank you. That's really helpful to have that overview. And what's the evidence for these restrictive practices being useful, and are they always useful? Do they ever exacerbate difficulties, do you think?
So I think there's very little research to suggest that restrictive practices have any long-term benefits for service users. So sometimes it gets argued that they're important for the safety of the ward, but the other people who've researched and worked a lot in this area commented that's actually a bit of a myth. I do think that they make staff feel safe sometimes, and I think I think I'll come on to why that can be a bit of a problem. But I think they work in a similar way to how perhaps like avoidance of our problems can make us feel better in the short term. Then, of course, sometimes that avoidance makes us feel better to the detriment of our longer term goals and plans. So I think the only real benefit they have is in managing imminent risk of harm. And my view is that, is a view I share with many others, including like the government, is that their use should only ever be used for this purpose. So I do think that they have a place, but only if they're used carefully and like judiciously, and if they're subjected to scrutiny and close monitoring. And that's really because there's a huge body of research that tells us that restrictive practices often result in harmful consequences for the people or for the service users who experience them. So service users who've experienced these types of interventions or been made subject to these types of interventions have quite often reported feeling traumatized or having previous experiences of trauma triggered. People report feeling afraid, powerless, angry. It's been described as being degrading, humiliating. Of course, they've also been associated with physical health problems and extreme instances, death of service users as well. So if we think back to like well-known cases and inquiries such as like Rocky Bennett, who sadly died in a medium secure unit. I think it was back in the late 90s or something like that, wasn't it? Largely because of physical restraint. So it really is no wonder then that some researchers and clinicians are of the view that these practices violate human rights of the people who experience them. And then when we think back to the idea about like mental health problems and psychosis developing as a result of trauma and adversity, then we really need to ask, are these services that use interventions that make people feel powerless, traumatized and emotionally distressed ever going to be able to effectively and consistently help people to recover? And this is, this becomes particularly salient when we think, like when people have described how restrictive practices as being really quite prevalent in mental health services and an integral part of forensic psychiatry.
We just had very recently, in fact, Dan had a conversation with Jessica Pandian of Inquest, who was talking about institutional racism. And I suppose one of the things that came up there was the application of restrictive practices being disproportionately applied to racialized groups of individuals. Yeah. Is that something that's come up in your literature review?
Yeah, it is. And like differences perhaps in the way in which, as well as like racialized groups, but differences between like men and women as well. And then we go back to like when I mentioned about Rocky Bennett and that idea about institutional racism. It was considered to be a huge factor in his death.
Mm. And you mentioned that staff often use them to feel safer, but I also wondered whether staff, I think we can probably all recognise times when staff teams have felt very angry and there's been a clamour for more restrictive practices, perhaps because of anger that might not be acknowledged openly. And I think sometimes as staff, you end up, as psychologists, psychotherapists, end up walking the line where the staff group might not feel protected and looked after enough, and yet we also have a responsibility to look after the patient and make sure the patient's not being treated in a way that's punitive. Is that a dynamic that you recognise from your work?
Yeah, it is. It is, yeah. And I think just to sort of break the question down a little bit, that the emotional experiences of staff are really important when we think about things like restrictive practices and trying to reduce them. So, for example, higher levels of anger and fear among staff have been associated with higher endorsement of restraint use, as well as actual increased use of restraint and seclusion. Things like low morale among staff has also been associated with repeated restrictive practice use. It kind of makes sense if we think of the environments where members of staff work as well. So they can be really quite challenging and dangerous. So then, what we think kind of happens, and what I alluded to earlier, is that restrictive practices become a way to contain and reduce the threat that might be posed in these environments, which in turn helps the staff to feel safe, and subsequently reinforces the use of restrictive practices, I think. And there's all sorts of like cognitive strategies as well that staff use to cope with the challenging situations they find themselves in, I think, but actually cause some problems when it comes to restrictive practices and reducing restrictive practices. Things like detachmental othering, or things like bravado, or all those types of things can really be tricky sometimes, because it can really influence the attitudes and the cultures of the work environment. And we know that's important for loads of reasons. So then you talked about as like a psychologist or psychotherapist trying to kind of manage the I suppose the splits that sometimes we see in between staff who work day to day, 24 hours with service users, and then like perhaps the multidisciplinary team who see the service users far less often. And I think it's a tricky thing to try and address, I think, and I think it's like a common challenge as well. I do think there's a few things that we can do to sort of help with this sort of thing, and I think essentially it probably sounds a little bit cliche, but I think a lot of the time what it comes down to is like communication and how and what teams communicate with the staff who are providing the day-to-day care. So I think things like being transparent with decision making, communicating the reasons for decisions helps, not just sort of enforcing the decision on people, asking them to do it. And that includes like decisions around restricted practice as well. Trying to balance the views of everybody and take on board. I think quite what can happen sometimes is that the sort of views and opinions of the day-to-day staff can be missed. But it's just trying to sort of show that those are considered, and then acknowledge and validating like anxieties or frustrations that staff might have, and sometimes just helping the staff to feel valued. I've met a lot of staff who work day to day on the wards, do fantastic work in really challenging environments, and they don't feel very valued sometimes. So I think that can help. And then,
that's such an important point, isn't it? I think when we know that for staff to be compassionate, they need to feel that they've been treated compassionately themselves, and it's quite hard, I think, when you see staff perhaps not being treated in an optimum way, and that might be due to lack of resources or other pressures that are very difficult for the organisation. But at times the staff's use of restrictive practice might be reflecting how they're being dealt with themselves by the organisation.
Yeah, definitely. And then I think there's some real kind of scope for like psychology with this stuff, and sharing like our psychological understandings and perhaps formulations, we might call them, to help people to really understand why service users are doing the things they're doing, perhaps, and then why perhaps being really restrictive and punitive towards them they're unlikely to be helpful. Because I think sometimes it can be quite often when people are quite new to these services, there's just this idea that if people have really harsh and I suppose it reflects societal kind of views more broadly, doesn't it? But if people have more harsh consequences and you treat them really punitively, then it'll motivate them to change. And of course, that's usually has the opposite effect, actually.
Yeah.
So I think all that sort of thing, and then perhaps even having conversations about and educating people about the harmful effects of restrictive practices, like we do in the service where I work, we all the psychologists do reflective practice groups for the staff. So they really do provide a good opportunity and forum to kind of address some of this stuff. I think the last thing I would probably say about it is about staff supervision as well, staff sort of clinical supervision, and I mean the staff who work day to day with service users, because in services where I've worked in the past, this hasn't always been something that's done with any degree of consistency or quality sometimes. And you think like I just think that my own clinical supervision is so important to keeping me well and healthy in work. And then there's people who work in a more intense way with our service users than I do, who have limited opportunity for that stuff. So I do really think that's something that could be helpful.
Thank you. Sorry, David, I think I ran away with all the questions there. So
that's fine. So I just want to touch a bit upon environment, because you mentioned it a bit earlier on, but do you think the physical environment or building can play a role in whether restrictive practices are more likely to be used? Yeah,
absolutely. So like what the research tells us around this is that there are a number of environmental factors that seem to be relevant to both like incidence of challenging behaviour and restrictive practices as well. So like ward environments that are comfortable, clean, spacious, well maintained, are associated with less incidence of challenging behaviour and restrictive practices. It seems to help if there are places for privacy that service users can access, as well as kind of ensuring that wards are not too crowded and too busy. And then kind of linking to that as well is that managing the level of sensory stimuli can seem to help. There's quite an interesting study by Yakov and colleagues, I think 2017, it was published, where they found that reducing light and sound levels during busy or stressful periods on an acute mental health ward was associated with a reduction in assaults and restraints.
Have you looked at kind of like staff turnover as well, and kind of like the consistency of a staff group, because that always seems to be something that triggers more incidents in secure services? Yeah,
you're absolutely right. So there's staff factors as well that contribute to this in a similar way to like what I was just talking about with the environmental factors. So staff who are more experienced, have more training, they tend to be more confident in using less restrictive approaches. Higher levels then sort of conversely, I guess, higher levels of experienced or temporary agency staff associated with higher levels of restrictive practices. So like the sort of skill set of staff as well, the staffing ratio and the staff mix, the opportunities for training, all these things can really contribute to the kind of likelihood of staff using restrictive practices.
But what about the culture of an organisation? Can that play a part as well in the way in which restrictive practices are used?
Yeah, so like the organisation, so I guess factors at the organisational level are really, really important, because I guess what they can do is influence the important factors, like some of the stuff that we've talked about here, like staff skill set, staff mix, staff training, environmental factors. They all sort of determined at the organisational level. And then there's things like policies and procedures that are obviously determined at the organisational level, which we know can affect restrictive practices. For example, it's been found that unclear policies are associated with higher restrictive intervention use. Things like efficient, objective like complaints processes, efficient investigation processes, or things like that are thought to help reduce challenging behaviours and restrictive practices. And of course, leadership then is another organisational factor that we might think about. And again, we know that what the research tells us is that that's really important to reducing restrictive practices, because good, strong leaders can influence the philosophy, culture, and then like the prevailing attitudes of a service, as well as helping services to stay on track or implement reducing restrictive practice interventions.
That's such a good point, and I guess also leaders who are present. So I suppose the most recent controversial exposure of abusive patients in hospital that we've perhaps seen on the TV has been the Edenfield unit in Manchester, but it's one of many. And I think those of us who work in forensic services are not surprised to see that these kind of events occur. And I think what's always interesting is people focus on the individuals that are acting out this abusiveness, rather than there tends to be a failure to attend to the leadership, and why didn't the leaders know that the culture was that bad. So I wonder, is there anything, I mean, the Edenfield unit, I believe, had recently passed a CQC inspection, and that's not unusual to be a factor in when these units get exposed. What could the CQC be doing differently to be more effective, do you think? Is there anything that they could do?
Yeah, and I think it's a really good question. And of course, with the recency of the scandal, I guess, that you're talking about, it's a really salient point, isn't it? And I think bodies like the CQC or the HIW that we have here in Wales got a bit of a difficult task. So hospital wards, particularly the ones that are a bit more secure, they're kind of by definition closed off to sort of outside monitoring and perspective, if you like, and to degree, they have to be to ensure things like confidentiality and the security of the environment. But when we do look at investigations of like abuse scandals, so not Edenfield, but when we go back to things like the View, when the people have done the inquiries and investigations into them, we see things like closed cultures being identified as contributing to these problems. And so that the problem is that secure environments really do lend themselves to this sort of thing. So it really does become difficult for bodies like the CQC to get a true reflection of how wards are day to day, because ward teams will always get a bit of a heads up that somebody's coming onto the ward because they have to, because of policies. I think sometimes in some places it can be difficult for even managers within the unit or multidisciplinary teams within the unit to get a true reflection of what goes on. So it can be really, really tricky. But I do think that anything that we can do to increase our ability to be open and transparent would be helpful. So I know things like CCTV use and body-worn cameras in mental health services is quite a controversial topic. I do wonder whether they would be a benefit for those sorts of reasons in some places, maybe. And then the other thing to consider is that when we look at investigations into these types of cases and incidents, what we see is high levels of restrictive practices being used. So like I referenced Winterbourne View, I think one of the findings was that there's an extortionate rate of physical restraint being used in that setting. So I do think there's something about restrictive practices, restrictive interventions, and like abuse of service users kind of sitting on this continuum. So I think if we can monitor and measure the restrictiveness of the service in a robust way, and address any problems around elevated restrictiveness early, I guess by thinking about some of the things we've talked about today, like staff emotional experiences, like attitudes and cultures, and I think that might help to prevent things escalating to the point where staff become abusive. The other thing I think is really important is for services to sort of face up to this stuff as well and turn towards our capacity for even our own services to wind up in this sort of situation if things were to go wrong. So you quite often see in the aftermath of these cases, you get other services saying things like, I'm proud to guarantee that none of this goes on in our services, and nothing like this will ever happen in our services, because that risk is a real possibility for all services. I think, again, because of the factors that we've talked about. I don't think there's anything about services like Edenfield or the Boneview that makes them inherently abusive. I think just things sort of evolve and change and slowly move away from good quality care over time, along that sort of continuum that I referenced, I guess. So I do think there's something about facing up to our capacity and doing something about it, to our capacity to find ourselves in a situation if we're not careful.
Yeah, such an important point. So Dan, what have you learned about yourself over the course of your work as a psychologist, and how do you make sure you keep yourself healthy when you're working in such a challenging setting?
Yeah. So I suppose the first thing that springs to mind is that what it's like as working in the psychology or psychotherapy. There's something about our ability to be quite reflective about our experiences and ourselves, I guess. And this is something, isn't it, that's drummed into us as we go through our training. It's something that we have to practice over and over again, and talk to trainees about the experience. They feel a little bit like death by reflection, but it is all really good, important stuff. And I do think that that's helped me to have quite a good understanding of myself, and be able to understand how my own experiences have impacted on me and kind of led me to be the version of myself that sort of sits in the world today. I suppose that does help in terms of like certain tendencies that I might have that could, if I weren't careful, lead to things being a bit tricky for me or for my loved ones. So then it allows me to kind of think about, what it is that's going on. I could do something about it. And then in terms of keeping myself healthy, so I guess there's sort of work stuff that's I think is important, and then stuff outside work. So in work, like I talked about earlier, having really good supervision and a good relationship with my supervisor. I often say that I can feel when I'm doing supervision, because it's just so helpful to help me keep sort of healthy and competent, I suppose, and good sort of peer support and peer relationships as well. I'm really lucky to work in a large psychology department with some great people, and also those sort of peer kind of relationships with the MDT members as well. What helps me is that I have quite in the things that I do, I have quite a lot of variety in my work. So there's the clinical practice side of things, there's the research stuff that I do as well, and I also do some private reports as well. So it's really quite nice, varied experience that I think helps me things to feel fresh for me. Of course, it does mean that things can, if you're not careful, they get on top of you, but it's just like some good organizational skills, then I think it's more of a help. No problem. And then outside work, it's just probably the usual stuff that people talk about. Quality time with like my wife and family, doing nice things, or perhaps just just getting like a takeaway and watching some crappy TV or something like that. That's all kind of really helpful stuff that I think helps me to stay healthy in work. Quite often I sign up to sort of ultra endurance events. So more often than not, I'm doing some sort of exercise training for something, whether it's like ultra running or triathlon. So usually doing some sort of running or cycling or swimming, or I live quite close to the Brecon Beacons National Park in South Wales. So just spending time out in the mountains is something that I really enjoy and I find helps me as well.
Great.
Brilliant, Dan. Thank you very much. I think we could have made that conversation going for a lot longer with a lot more questions. It's just unfortunate we do try and keep them to an hour, but I think we'll have to have you back on talking about your research when it's concluded, or even compassion focused therapy, which I know you're also very interested in.
Yes, yeah. Anytime. It's an absolute pleasure to chat with you this afternoon.
Thank you.
Great to meet you, Dan.
You too.